peptides and um, carbohydrates, etc., into smaller substances, which at the end product is really your monosaccharides as it relates to carbohydrates, and amino acid as it relates to proteins. And for fats, it's really what? Fatty acids and glycerols. So the whole process in terms of the function of the GI tract involves ingestion, digestion, absorption, excretion. I think we're more focusing on ingestion and mainly digestion, particularly as relates to the stomach. There's chief cells and parietal cells, and the endocrine cells involved, the G cells, which secretes gastrin. I think that's our main focus today. So, carbohydrates are broken down, really starch, broken down to disaccharides and monosaccharides. Well, monosaccharides, which are then converted into monosaccharides, so like lactose and galactose and fructose, which we'll speak about in the next lecture. And there are these enzymes which breaks down, for example, lactase breaks down lactose, etc. So biochemistry test has very limited diagnostic use as relates to gastric disorders. So for each, there may be just one particular test, and some of them are very complex. But in a routine laboratory setting, the tests are very few as relates to diagnosing disorders of gastric functions. So it's more radiological procedures which are more which has more use in diagnosis. One of the hormone that we need to look at is gastrin, and gastrin is a major physiological regulator of gastric acid secretion, and we're not able to measure gastrin because gastrin is very unstable. It requires a particular procedure or machine or equipment which we're not able to afford. It is a hormone produced by the antral cells or G cells in the stomach mucosa, but there are other sources which produce gastrin, such as the G cells of the duodenum and delta cells of the pancreas. So this just tells us the duodenal G cells, the antral G cells, the delta cells of the islets, which produces gastrin. So, just biochemically, you have pre-progastrin, which is a polypeptide, and cleavage of amino acids produce gastrin of three forms. There is the mini gastrin, small gastrin, and large gastrin. I think what we measured, what is measured in the laboratory outside of our jurisdiction, is really gastrin, and maybe the large gastrin. Not important in terms of its structure. So there's pre-progastrin, then progastrin, then the three gastrin. There's gastrin, mini gastrin, large gastrin, etc., which are shown. But really, what is measured is really maybe the large gastrin, and it's referred to as gastrin. So gastrin is produced, and it is triggered in terms of its release from the duodenum, these G cells, when the food enters the stomach, and the stretching of the stomach causes the release of gastrin. Again, gastrin is produced by these three sources as shown, and it travels to the stomach where its main function is to stimulate the parietal cells, and they produce hydrochloric acid. So gastrin again has a diurnal variation, etc. So gastrin is that peptide hormone, stimulates the secretion of gastric acid, particularly HCl, by the parietal cells of the stomach, etc. And therefore overproduction will lead to the formation of peptic ulcer, etc. So again, it's in terms of optimal secretion is when the pH is between 5 and 7, and as the pH drops, then its release decreases. And note that at pH equal to 1, there is inhibition of gastrin. So its main function is the production, in essence, of HCl. But there are different causes of gastric hypersecretion. If there's inflammation of the gastric mucosa, a critical point for us is excessive secretion of gastrin, particularly Zollinger-Ellison syndrome. I think that's our main disease that we need to look at. And there are other, such as aspirin, NSAIDs, hyperthyroidism, hypercortisolism, which causes increase in gastric secretion. So our main disease at this point is Zollinger-Ellison syndrome. And I think the important thing is, how do you diagnose a patient with Zollinger-Ellison syndrome? Biochemically. So it's a tumor of the gastrin secreting endocrine cells of the pancreas, less frequently the duodenal wall. And of course, with increased gastrin secretion, there's increased HCl production by the GI tract. And this can cause the formation of serious and aggressive peptic ulcer. So again, this tumor produce, which is really a gastrinoma, gastrin-producing tumor, increased HCl in excess, and therefore leads to ulcer formation. It causes, of course, in Zollinger-Ellison syndrome symptoms clinically: abdominal pain, chronic diarrhea, weight loss, GI bleeding, etc. And of course, ulcer formation as a result of that. So it's a gastrin-secreting tumor. So how do you diagnose Zollinger-Ellison syndrome? Of course, it's really an increase in gastrin level. So the fasting gastrin level is measured. The reference range in a normal individual is 0 to 100 picograms per mil. So values of 1,000 picograms per mil is really diagnostic for Zollinger-Ellison syndrome. So I put this slide in at the top, which is a very important one, that the normal levels of serum gastrin is 0 to 100 picograms per mil. So if the serum gastrin level is greater than 1,000 picograms per mil, that's diagnostic for Zollinger-Ellison syndrome, ZES. Of course, with a pH less than 5. But they find that values greater than between 500 and 1,000 also is diagnostic or consistent with patients with ZES. And usually, most 40% of patients has a plasma gastrin level or serum gastrin level between 100 and 500. But really, greater than 150 normally is 0 to 100, then that suggests that the patient has ZES. But greater than 1,000 is really diagnostic. There's nothing else that you need to do. So most patients with ZES has a serum gastrin level between 150 and 1,000, noting that the normal level is between 0 and 100. So in cases where the physician is uncertain, maybe about 120, 130, 140, then they do what is called a dynamic function test, which is your pentagastrin test, where you're going to stimulate to some amount of stimulation. So they measure the basal what's called gastric acid secretion in terms of gastrin producing HCl. So they measure the content of measure the gastric acid secretion. And of course, the procedure involves fluid aspirate through a nasogastric tube in the fasting state, as well as when pentagastrin, which is a synthetic polypeptide, which is similar to gastrin, is administered. The process involves entering the stomach of resting contents, collect that basal gastric juice, which would have your acid, then inject pentagastrin, and then you collect samples, 4 samples within a 15-minute interval, and analyze the content. So you really want to look at your acid output or your HCl content. So there's a normal range for the basal acid output before pentagastrin is given. So less than 10 mils in males and less than 5.5 mils in females. And then having given pentagastrin, you expect that the HCl content or the acid output would be increased. And there are reference ranges for males and females. But what is more important is to look at the ratio of the basal acid output to that of the maximal acid output. So if the basal acid output, maximal acid output ratio is less than 0.6, that's diagnostic for Zollinger-Ellison syndrome. So one unequivocal basal gastrin level, let's say 120. Physician does the pentagastrin test, which, just going back, empty the stomach, collect the basal, that basal acid output, inject pentagastrin, collect samples, and the reference is looking at the basal acid output, maximal acid output ratio greater than 6.5. That's diagnostic for Zollinger-Ellison syndrome. So review question is, what is ZES? Laboratory findings is really, one is to look at your what? Your serum or plasma gastrin levels basally, greater than 1,000 picograms per mil, that's what? Diagnostic, all right? Normal is between 0 and 100. So with values 500, almost that's really diagnostic too. But values of 120, 130 with signs and symptoms, the physician does the pentagastrin test. Enter the contents, take a basal gastric acid output, give pentagastrin, take values, look at your maximal after pentagastrin over your basal, that ratio greater than 0.65 suggests the patient has Zollinger-Ellison syndrome. That's fine, number one. So one is your gastrin levels greater than 1,000, diagnostic. Unequivocal values, do your pentagastrin test. Basal acid output, which of course has HCl, in terms of your gastric juice, over maximal, greater than 0.65, diagnostic.
So the pentagastrin is just you adding exogenous gas?
Yes, it's the analog of gastrin, sure. So it does the same thing as with a gastrin message. So it causes HCl production.
You just want to see if the person already have enough gas to produce.
Yes, excellent, yes. Yeah, so there's gastrin, which is your hormone, agree? But you know that gastrin produces HCl, agree? So one is you want to see if there is overproduction of HCl. So you cannot stimulate to produce HCl. So look at what is basal, do your stimulation, what's maximal, and if the basal, because the basal is what is more important, if the basal is more than, in terms of the ratio, greater than 6.5, then that's diagnostic. But of course the basal is on top. All right, that's fine?
So if it's high on top, that means you have a small ratio. It's very...
Sure. And that 0.65 is, so even though the individual is high, but look at that ratio, which will tell you. All right, that's fine? Okay, so moving along. So that's a review slide. Okay, so moving on to the pancreas is an endocrine and exocrine organ. We know that endocrine is really a secretion of hormones such as insulin and glucagon, etc. And exocrine is what is important to us in terms of the pancreatic juice. So the exocrine pancreas, in terms of digestion, you have bicarbonate, lipase, and amylase. I think that's what is more important to us. And of course, the pancreatic juice will consist of bicarbonate and enzymes, which breaks down carbohydrates, proteins, lipids, etc. So you have the endocrine function, you have the exocrine function. Of course, there are these enzymes which are involved in terms of secretion of alkaline fluid, which is just a secretin, and cholecystokinin, which secretes stimulates the secretion of pancreatic enzymes. So these are critical in our context. We don't necessarily measure them, but overseas they are. But they're quite useful. So in terms of investigation of pancreatic disorders, I think what comes to mind is what? Acute pancreatitis and chronic pancreatitis, all right? Of course, cystic fibrosis is also important, which we'll not do in this lecture. So question is, how do you investigate a patient with acute pancreatitis? I think that's the question that needs to be asked. What are the biochemistry tests which are useful? So acute pancreatitis is really inflammation of the pancreas. Your acinar cells become inflamed, cell necrosis, cell death, etc. And of course, there's release of enzymes which cause autodigestion. And so you have the associated abdominal pain, etc. So there's a release of these enzymes into the bloodstream. And two critical enzymes are amylase and lipase. So the question is, for acute pancreatitis, which is the better test for diagnosis of the disease? So that's the important thing. Of course, acute pancreatitis means that there is reversible pancreatic parenchymal injury, which is associated with the inflammation. So you have the etiological factors: alcoholism, biliary tract disease, drugs, infection, causes activation of these pancreatic enzymes, this injury to the pancreatic cells, and of course, these enzymes are involved in the whole autodigestion process. So, of course, in the pathogenesis, there's pancreatic duct obstruction, there's pancreatic acinar cell injury, release of your pancreatic and lysosomal enzymes. But the lysosomal enzymes are involved in the whole autodigestion process, activation of the enzymes, and autodigestion of the pancreas. So what's the laboratory investigation in terms of acute pancreatitis? Well, it's really looking at lipase and amylase. Of course, this just talks about the different causes of acute pancreatitis in terms of excessive alcohol and gallstone, etc. Triglycerides elevated also cause acute pancreatitis as well as hypercalcemia. So again, causes: alcohol, gallstones, medications, infections, tumors, high triglyceride levels, high calcium levels do cause acute pancreatitis. But in terms of laboratory investigation, it's really very important slide: serum amylase, serum lipase, and I would say 24-hour urinary amylase, all right? So it really should be 24-hour urinary amylase, which is best in diagnosing acute pancreatitis. You also want to include glucose, calcium, and triglyceride, because high calcium and high triglycerides are also causes of acute pancreatitis. So, of course, in terms of the triad, abdominal pain, serum lipase or amylase, usually 3 times upper limit of normal, and your characteristic CT findings are involved. So, which one is better at diagnosing acute pancreatitis? The answer is serum lipase. So, serum amylase onset almost immediately, peak within several hours. I think this slide, if I should just go, this slide is better. So, increase in 2 to 12 hours, peak in 12 to 72 hours. I don't think you just need to appreciate this, but it's normal within 3 to 4 days. Of course, urinary amylase is done, but of course, it's not a good test because you have issues with collection of urine. And note that it is, even though it's increased, it has a longer stay in the urine, in terms that it can be raised 2 weeks after the attack of acute pancreatitis. But if you should compare serum amylase to urine amylase, the better test for diagnosis of acute pancreatitis is serum amylase. So going back, just going back to the slides, serum amylase onset almost immediately, peak within several hours, 3 to 4 times upper limit of normal within 24 hours, as at 90% sensitivity. Lipase, on the other hand, is more sensitive and is more specific than amylase. Amylase comes from different sources, all right? Lipase is more specific and also more sensitive. So this just shows in terms of the elevations of amylase, so and urinary amylase. So in essence, the better test is really lipase. Yes. So this is lipase. So it increases in 48 hours, peak at 24 hours, but note that it remains elevated longer than amylase. So even though amylase may rise earlier, 2 to 12 hours, I believe, compared to lipase, which is 48 hours, The lipase amylase, as in serum, decreases within what, 3 to 4 days? Lipase within what, 8 to 14. So it stays up longer, which allows you to diagnose the patient over a longer period of time. So very important slide, which is this one, is that so in essence, the normal range for amylase is 80 to 98, but generally, overall, is not very specific because you do have amylase from the pancreas as well as the salivary gland. So that lessens its specificity. And usually, however, it's usually increased in patients with acute pancreatitis, but it is not good. So values 10 to 10 times upper limit of normal is virtual diagnostic for acute pancreatitis. So values of amylase increases in acute pancreatitis. Once it's 10 times upper limit of normal, the range is 0 to 98 normal, so 980 and above, that's diagnostic. But you can also have increase in amylase in perforated duodenal ulcer, intestinal obstruction, and other acute abnormal disorders. So there's an issue with its specificity. Even renal failure and diabetic ketoacidosis. Lipase, on the other hand, the range is given. Measurement of serum lipase is more specific and more sensitive than serum amylase for acute pancreatitis. So 3 times the upper limit of normal is really diagnostic. And so what you can do is just to combine both serum amylase and serum lipase, and the overall diagnostic sensitivity and specificity actually increases for acute pancreatitis. Important slide, that serum lipase has a higher sensitivity and specificity. It has a larger diagnostic window than serum amylase because it stays up longer, thus allowing diagnosis in terms of early stage and late stage acute pancreatitis. So just a comparison on amylase and lipase. Serum amylase, rapid rise, short-lived, urine persists longer. Lipase, slow rise in the blood, lasts longer. So you can actually follow us in terms of early stage and late stage acute pancreatitis. In addition to acute pancreatitis is that you have lipase lipase, an enzyme which breaks down fats. So you're going to have fatty acids and glycerols, etc. So you can have increase in triglycerides. And if alcohol use, we said in terms of liver function test, GGT is affected, can cause damage to the hepatocytes. So if acute pancreatitis is due to alcohol use, you can have your deranged liver function test, etc. All right, so review question is acute pancreatitis. I think the important thing is, what are the 3 tests for acute pancreatitis? Serum lipase, serum amylase, urine amylase. So the best of the 3 is really serum lipase, all right? Even though there's a slower rise, but it has better sensitivity and specificity compared to serum amylase. So in essence, it would be serum lipase, then what? Serum amylase, then urine amylase in that sense. All right? So I think that's the take-home message really from that. All right. So in addition, you would want to do your secondary tests such as calcium and triglycerides because they also cause acute pancreatitis. But I think in terms of diagnostic, it would be serum lipase, serum amylase, and urine amylase in the next. So that's a very important point to remember. All right, I'll just allow you to look at that when you revise. Now, chronic pancreatitis is a benign, inflammatory, irreversible disease. There is reversible morphological changes, progressive, and there is permanent loss of both exocrine and endocrine functions. So, in essence, alcohol is a cause. So, acute pancreatitis not treated, then it possibly progress to chronic pancreatitis. So let me ask you, for chronic pancreatitis, do you think that amylase and lipase has a place in diagnosing chronic pancreatitis. One of the concern, however, is that there is ongoing progression, progressive decrease in your acinar cells, parenchyma acinar cells. So you'll find that as it is progressed, you have less functional cells. So possible your amylase and lipase may be normal. Just like the liver, yes. So really, amylase and lipase are not the best test for diagnosing patients with chronic pancreatitis. Good for acute, but not necessarily chronic. So the question is, what test, biochemical test, is useful for diagnosing chronic pancreatitis? Of course, the radiological tests, of course, that are useful. So laboratory-wise, it really is to look at the test exocrine function and look at really pancreatic insufficiency, because there are some enzymes which are secreted by the pancreas, and their activity or the levels can be measured, which gives an indication of the functionality of the pancreas. So in terms of laboratory, the enzyme is fecal elastase, right? Not offered locally, but more overseas. So let's look at fecal elastase. So therefore, if elastase is the enzyme, it's a protease enzyme which breaks down proteins and polypeptides, of course, and peptides, to amino acids, and it is synthesized by the pancreatic acinar cells secreted in the duodenum. So it's really synthesized by the pancreas, synthesized by the pancreatic acinar cells. So it means that if there is decreased function of the pancreas, it means that there's going to be decreased elastase level. One thing is that elastase, when it is secreted, can actually makes its way through the digestive tract based on its structure, etc., is not degraded by your intestinal juice. It actually can pass through, makes it transit through the digestive tract and pass out into the feces. So that's what makes it a very good test, and therefore is fecal elastase, which is a test. So there's a reduction in chronic pancreatitis, there's a reduction in elastase production because of the fact that you have less acinar cells that have been damaged, you have less productive, less functional cell mass. So there's going to be a reduction in elastase production due to, of course, exocrine insufficiency. So therefore, patients with chronic pancreatitis will have low levels of elastase in their feces. So it is said that the test is widely available, not here, overseas. It's non-invasive and cheap, maybe 50 pounds possibly, all right? Not affected by enzyme use, etc. Does not require times tool collection, etc. So measurements, it involves 5 grams of stool, collected I think over 3 days. ELISA is used for its measurement. Note that it is used for diagnosis of any pancreatic exocrine insufficiency, chronic pancreatitis, cystic fibrosis, pancreatic tumor. Especially the first two is quite useful for diagnosis of chronic pancreatitis and cystic fibrosis. Reference range, very important slide, is that normal pancreatic sufficiency or normal levels of fecal elastase is 200, is greater than 200. Let's say greater than 200 units per grams of elastase, E1 per gram of stool. So greater than 200 of units per gram of elastase, which is E1 per gram of stool. And that suggests normal exocrine pancreatic sufficiency. If there's mild to moderate, as in decrease in fecal elastase between 100 and 200 per units per gram of elastase per gram of stool, that's mild to moderate, and severe is less than 100 micrograms of elastase per gram of stool. So really, pancreatic sufficiency is less than 200. Yes, question.
For the normal, is that a greater than, say, 500?
Yes. So in a sense, it should be greater, let's say greater than 200. Let's put it that way. 200 and greater. Even though I put it 200 to greater than 500, let's say greater than 200, that's normal. All right. So greater than 200, that's normal. I'll not to confuse you. Greater than 200, normal. Less than 200, evidence of pancreatic insufficiency, so you have decreased production of elastase. So in terms of looking at the elastase in the stool. That's fine, everyone? So I think the take-home message here, because we say for acute pancreatitis is what? Serum lipase, serum amylase, and urine. For chronic pancreatitis, it is decrease in fecal elastase. That's the message. Less than 200 micrograms of elastase per gram of stool. All right, so I think that's what this. So again, fecal elastase is the most important thing, etc. So review question: what is chronic pancreatitis? Laboratory findings in a patient with chronic pancreatitis is really decreased fecal elastase. Less than 200 micrograms of elastase per gram of stool. And note that, of course, that serum lipase and serum amylase are really usually normal in patients with chronic pancreatitis. All right, so I'll just move on to test of pancreatic function. I think I may have done one question already. So you can actually measure the elastase in feces, which gives an indication of pancreatic function. And that enzyme is elastase. You can actually gives an indication of other pancreatic enzyme activity, which gives an indication of your pancreatic function. So you can have what I call indirect test, and one is fluorescein dilaurate test. Indirect test of pancreatic function. So it's a non-invasive test of pancreatic exocrine function. And while we say that enzyme was elastase, the enzyme produced by the pancreas is pancreatic cholesterol ester hydrolase. It's a hydrolysis enzyme. So you actually measure the ability or the extent of hydrolysis of certain substances and to give an indication of the pancreatic function. All right, so let me, so that I don't confuse you. Okay, so the procedure is, so the substance that you give the patient is called fluorescein dilaurate. 1 tablet of fluorescein dilaurate. So day 1 tablet of fluorescein dilaurate. And so what will happen is that enzyme, hydrolytic enzyme, will split the fluorescein from the dilaurate. So therefore, if you have sufficient adequate amount of enzyme, you expect that hydrolysis, where you split the fluorescein from dilaurate and you have free fluorescein. All right. Day 2, same procedure, but you give the patient only free fluorescein. And you're going to get a ratio of the fluorescein from day 1 to that of day 2. All right, so so again, day 1, fluorescein dilaurate, pancreatic esterase, which is a hydrolysis enzyme, going to split the fluorescein from the dilaurate. So you're going to have what? Free fluorescein. And he said that this is go to the liver, is conjugated, passed, all right, passed out in the urine. So you're going to look at the ratio of the free fluorescein on day what? Day 1 to that of day 2. Is that okay, everyone? The enzyme is just going back. is a cholesterol ester hydrolase. All right, so it's an enzyme produced by the pancreas. So therefore, if you have adequate amount of enzyme, it means that your fluorescein on day one, let's say 20% is the benchmark in a normal individual. Your fluorescein on day 1 to day 2 should be greater than what? 20%, agree? All right, so just put in there. So look at fluorescein excreted on day 1 to fluorescein excreted on day 2. So normal pancreatic function is really greater than, let's say, 20%. Right, there's that middle ground between 20 and 30. Right? So less than 20% really suggests that you have less functional enzyme and therefore pancreatic insufficiency. All right, so again, just going back to this. So the pancreatic hydrolase esterase will split the fluorescein from the dilaurate. This fluorescein becomes conjugated in the liver, but its essence passed out in the urine. So the more enzyme that you have, it means that the more what? Fluorescein on day 1 would be produced or would be excreted in the urine. All right? And again, so it's the fluorescein on day 1 to fluorescein on day 2 times 100%. Normal pancreatic function greater than 30. This gray area between 20 and 30, less really is, yes. On day 1, on day 2, yes. So really what's important is that the fluorescein dilaurate on day 1, where that enzyme splits the dilaurate from the fluorescein. So the more enzymes that you have is the more fluorescein that will form on what? Excreted on day 1. All right? And so greater than 30% and less than 20% really indicates there's a gray area between 20 and 30. All right? And that just fluorescein absorbed by the intestine, conjugated, measured in the urine. Ratio greater less than 20 is considered abnormal. So severe pancreatic insufficiency would have values of 10%, 5%, etc. All right. And compared with fecal elastase, the pancreatic creolaural is really the fluorescein dilaurate test, which is number 2, and it's less sensitive and specific compared to fecal elastase. So fecal elastase is really a pretty good test. All right, so almost close to the end. So I think the take-home message there is to look at that ratio of fluorescein on day 1 with fluorescein on day 2, and the ability of that enzyme to do the split of the fluorescein dilaurate less than 20% suggests that the patient has pancreatic insufficiency, which really patient has chronic pancreatitis. Really is a test for chronic pancreatitis. All right, that's fine, everyone. Okay.
So to analyze that test, basically you have a certain amount of fluorescein, right? On day 1, that fluorescein was in our compound fluorescein
Laurent, yes.
So when you did it for day 1, you were seeing how much the pancreas would actually break it out to release that.
Sure. So I presume there's a split. The enzyme, which is the esterase, is a hydrolysis enzyme. We split the bond between the fluorescein and the dilaurate. So therefore, the more enzymes you have, the more you're gonna get that break, that bond being hydrolyzed. So the more fluorescein will be released.
But then on the second day, you just put in the
The fluorescein, which basically just the free fluorescein in day 2, which just basically is excreted freely. And that ratio of amount produced on the first day by compared to day number 2. Hope that's fine, everyone. So it gives an indication of the adequacy of the enzyme produced by the pancreas to split that fluorescein from the dilaurate. The more enzyme you have, adequate, greater the ratio. That's fine, everyone? Oh, okay. Finally, pancreatic cancer. So pancreatic cancer, as you know, is one of those which are usually diagnosed very late. And so mortality rate is very high. Overall survival, not pretty good, and usually diagnosed in the late stage. So the question is, do we have a biochemical test or tumor marker that can assist in diagnosis? So the survival rate is really what, 3 to 6%, maybe the 5-year survival rate. And there are a number of causes including smoking, diet, etc. So mainly imaging test, but in terms of biochemically, is a tumor marker which is called carbohydrate antigen 19. That's the test. So you expect that patient with pancreatic cancer will have elevation of carbohydrate antigen. So patient has cancer, release of this tumor marker from the pancreas, and it's an indication that the patient has pancreatic cancer. The issue is not a good screening test. So in early stage disease, CA99 may be normal, so which makes it not good for screening. And because the patients are diagnosed late, is when they're diagnosed when the cancer may have spread to the liver, etc., that you have these very high values. So it's usually diagnosed late. By the time they would have been spread to other to the liver, etc. The reference range is 0 to 37 units per mil. Values greater than 1,000 is really diagnostic for pancreatic cancer. So this just shows in terms of cancer stage at diagnosis. All right, usually less, most are localized, but of course, 5-year survival rate is really not good at all. So it's therefore useful for monitoring response to therapy. It is not a good screening marker. It is not a good diagnostic marker. It's really monitoring response to therapy. So I think the take-home message is that really, in terms of pancreatic cancer, CA99 is really useful for monitoring response to therapy. Values greater than 1,000 units per mil is really diagnostic for pancreatic cancer. But note that it is also increased not only in the pancreas, pancreatic cancer, but also in biliary cancer, in hepatocellular carcinoma, in gastric ovarian cancer. You do have increase in CA99, so it's really not very specific for pancreatic cancer. And so with not just, if you add the serum values to test to that of abdominal CT or abdominal ultrasound, the predictive value or sensitivity specificity also increases. So in essence, not only is there increase in CA125, but also if tumor at the head of the pancreas, you'll have dark urine, loss of appetite, light-colored stools, etc. And if it's spread to the liver, we expect increase in AST, ALT, GGT, as we discussed yesterday. I think this is my last slide. So in summary, what is this class all about? So one is ZES. So one is that there's increase in what? Serum gastrin. Reference normal is what? 0 to 100. Greater than 1,000 is diagnostic. Values of maybe 120, 130, you do what? The pentagastrin stimulation test. You got your basal 2-year maximal acid output greater than what? 0.65 is diagnostic. So that's 1. 2, acute pancreatitis. So the most sensitive specific is what? Serum lipase, then serum amylase, then amylase. And then chronic pancreatitis is diagnostic test is fecal elastase, but indirect test could be what? Your fluorescein dilaurate test. Look at the ratio of the fluorescein on day 1 to day 2. Less than 20% indicates pancreatic insufficiency, really chronic pancreatitis. And finally, for pancreatic cancer, it is what? CA99. Not a good diagnostic or screening marker, but useful for monitoring response to therapy. I think I just covered 3 questions in this. All right. Thanks everyone. See you, I believe, next week. All right, take care. So.